The thrill is not in winning, the thrill is in chasing. So that is the reason, doctor, today's evening is more glamorous and glorious than probably the day we join MD. So that's the reason, no setback. Let us take up this very important question, doctor. First of all, let us decide what is the frame of the question. Yes? I mean, maybe a patient of 60 years, 40 years would have been mentioned. At least what I understood is, there are bronchial breath sounds which are heard on the right side. Increased vocal fremitus is also there in the right infraclavicular area. And the trachea is also shifted towards the right side. What else was there? On percussion there is a dullness. Crepitations were also there. Very good. Now let us talk about this very important and interesting question. Basically it's a housemanship question, doctor. You have consolidation, pleural effusion, lobar collapse, pneumothorax and pleural thickening. 5 important entities which we should not forget. Now what are the important ways that we examine the, the respiratory system, doctor? You have mediastinal shift. Basically in consolidation there will be no mediastinal shift, or even in the case of the pleural thickening. In effusion there is a shift of the trachea away from that of the side of where the effusion is located. Then you are having the collapse of the lung where the trachea is shifted but towards the side of the collapse. So the 4th important scenario is the pneumothorax. If it is a simple pneumothorax, there is no shift of trachea. If it is a tension pneumothorax, trachea is shifted, is what need to be basically remembered. So first of all, there is a shift of the trachea towards the right side. Now tell me, doctor, what are the 2 possibilities? Either it is a pleural effusion on the left side, or it is a collapse on the right side, but there can be an effusion associated with the consolidation also. So shift does not still rule out. And similarly, there can be an obstruction in the bronchus leading to the collapse of the lung. At the same time, there can be a consolidation also associated with that obstructive phenomena. So all can occur in combination with each other. Now let us talk about the percussion note. Is it, what was the comment on the percussion note given? Dull percussion is there. So basically, doctor, everywhere there is a dull only possibility is pneumothorax where it is increased. In pneumothorax also you must be doubly sure about. Suppose if you say there is an increased percussion note, probably there is a pneumothorax from the right side, your colleague will say, no sir, there is a left side consolidation. This is the normal lung, hence you are listening it loud. Unfortunately, consolidation on the left side will be deceptively appearing as a pneumothorax on the right side while you are going for exam. So you must be doubly sure about. Then you are having what are called as a breath sound. Bronchial breathing is very much there. What is the meaning of bronchial breathing, doctor? Generally, bronchus is inside the lung. So whatever the sounds produced in the bronchus cannot be heard if you place the stethoscope on the chest. Something must be there in the lung, parenchyma. That is a consolidation which is removing that filtering ability of the lung. So consolidation classically produces the bronchial breathing. Just like you put the stethoscope on the trachea, the sounds that you listen it similarly on the lung also, then it is bronchial breathing. So it is consolidation which typically produces it. Coming to the added sounds, you have the crackles which are there. Are the crepitations and crackles are mentioned? So bronchial breathing is also mentioned. So but how do you explain with consolidation the shift of the trachea? So that can't be explained. So that is the only thing which is disfavoring the hypothesis of it being the consolidation. At least let us talk about the vocal fremitus. Typically the vocal fremitus will be increased if it is consolidation, then it is the collapse, then vocal fremitus is decreased. Now let us try to once more summarize all these clinical findings. What favors the consolidation in this given case given to you? Everything favors. Only thing is tracheal shift is not favored. Yes. No, consolidation per se, unless associated with the other pathology, cannot be able to shift the trachea. That is always the rule. If it is only purely consolidation given, then it can't shift the trachea. No, but it is not given. Fibrosis was not given. Yeah, I will also resolve some other part of the mystery. Now you are having a very important feature called vocal fremiters. Typically the vocal fremiters is decreased once there is a collapse, but there is an exception which is mentioned for this rule. The exception about a increased vocal fremiters or a normal vocal fremiters in spite of having the collapse is in only one scenario. If the collapse is involving the right upper lobe, because it is very close to the trachea, though it is a collapse, it won't lead to decrease of the vocal fremiters, rather it leads to a normal or increased vocal fremiters. That is the reason examiner favorably was talking about the right infraclavicular area continuously. Now everything got resolved. So it is the right upper lobe collapse which is there, and also the trachea got shifted. Now the only option that is there for us is, trachea also got shifted ipsilateral to the collapse. Collapse is on right side, trachea shifted towards the right side. Now the only thing is it a collapse with a patent bronchus or is it a collapse with a collapsed bronchus? Now let us try to argue on this very important fact. Basically, if you look at the lobar collapse, there is a diminished movement on the side of the collapse and the percussion note is markedly reduced if the whole lung is involved, and the breath sounds typically become diminished, and coming to the vocal resonance it also becomes diminished, and if it is an upper lobe collapse there is a bronchial breathing, increased vocal resonance and whispering pectoraloquy which is also heard, is what need to be basically remembered. Now the question is, if the bronchus which is causing the collapse, the collapsed lobe of the lung, the bronchus supplying it, is it patent or closed? What is a very important clue for it? Typically it is the bronchial breathing which will tell you. If the bronchial breathing is also heard, then that means to say that collapsed lobe of the lung is having the airway which is still patent. Suppose if the bronchial breathing is not heard, that means to say that that particular airway which is supplying the collapsed part of the lung is also collapsed. So there is a reason, doctor, because bronchial breathing is still heard, we can consider that it is a collapsed lung, but with a patent bronchus would be the possibility out of our ignorance. So let us, we are not very sure what were the other ideas behind framing this question. So no disheartening if you answered consolidation. Still consider until the result comes that it is the right answer. But still, by all this logic, the answer becomes the collapse with a patent bronchus in the right upper lobe. Now let us go to the next question, doctor. For the evaluation of the RPGN, rapidly progressive glomerulonephritis, what do we use? Now first of all, tell me, doctor, are these four options are given? Anti-endothelial antibodies are also there. Now let us ask a leading question to the chairman of the today's session, Narasimha will answer. Dr. Narasimha, what is the important condition where anti-endothelial antibodies are seen? One, vasculitis. Is it in the microscopic polyangiitis or is it in the polyarteritis nodosa? Which condition? In the case of the polyarteritis nodosa. Now my next question to you is, between polyarteritis nodosa and microscopic polyangiitis, which leads to RPGN, which does not lead to? The differentiating feature is polyarteritis nodosa does not lead to RPGN, whereas MPA, which is a very close end of the other part of the spectrum of the PAN, typically leads to development of the RPGN is what need to be remembered. That's the reason, doctor, whenever there is a rapidly progressive glomerulonephritis, we evaluate for the ANA, ANCA levels and also for what are called the serum C3 levels. Now my question to all of you, why should you evaluate the serum C3 levels in the case of the RPGN is my question to all of you. Very simple. First of all, before that, what is RPGN, doctor? At least 50% of the glomeruli must show the presence of the crescent formation. Point number one. Number two, at least within few days to 3 months, there must be a development of the renal failure. Then only it is called rapidly progressive. And there must be a fibrinoid necrosis which is being found in the renal biopsy. So all these things defines what is called as the RPGN. Now RPGN in turn is having three important etiologies. One is immune complex diseases are responsible for the RPGN in 45% of cases. Similarly, 50% of cases it is posse-immune, and in about 3% of cases it is anti-GBM is what need to be remembered. So in order to know whether this RPGN is due to posse-immune or immune complex, how do you know that? If it is immune complex mediated RPGN, then what will happen? complement become exhausted and the C3 levels will fall down. Whereas in the case of the post-immune type of RPGN, what will happen? C3 levels will remain normal. To know whether which is what, we basically do the C3 levels is what need to be basically remembered. So accordingly, you have some immune complex etiologies for the RPGN. You are having the anti-GBM antibody responsible, and also you have the post-immune. That is how it is being broadly divided into. Now I like to ask you, the last but not the least, a quiz question to all of you. Why do we do the complete blood picture in the case of the RPGN? Can you tell me one etiology which can be identified by doing the complete blood picture? Eosinophil count will help us, especially Church-Strauss disease. It is also notorious to lead to RPGN, is identified by the eosinophilia in the peripheral smear. That is the reason we do the CBP, is what need to be basically remembered. So that's the reason, doctor, in short, anti-endothelial antibodies are not done, but GBM, anti-GBM and ANCA and serum C3 are the ones which are commonly done, is what need to be basically remembered. Mononeuritis, multiplex, hypertension, renal failure. What is our favorite question, doctor, regularly we discuss? It is the polyarteritis nodosa where musculoskeletal symptoms and multisystem involvement, mononeuritis multiplex, which is one of the common features, and sciatic nerve is the one which is most commonly associated, is what need to be fundamentally remembered. Now, what are the side effects of tacrolimus? This is one rare question. Unless you are a regular nephrologist, you will not know about it. Why nephrologist tacrolimus? Because tacrolimus is basically a common immunosuppressant that we use in the renal transplantation, is what need to be remembered. Now basically, doctor, it is used in the allogenic organ transplant as an immunosuppressive agent, and also it is used as a topical preparation in the atopic dermatitis also, is what I want to underscore to all of you. Now what are the important contraindications? IV administration is contraindicated, oliguria, pregnancy, QT prolongation, sunlight exposure, they are all contraindications. Now what are the side effects of the tacrolimus, doctor? Typically the blurred vision, tremors, hypertension, hypomagnesemia, hyperkalemia, insomnia, loss of appetite and hyperglycemia, they are all the important features. So diabetes very much happens if you are using the tacrolimus, and hypomagnesemia also will happen. Nephrotoxicity, neurotoxicity are very well known, but gingival hyperplasia does not occur. So which is the other important closely related immunosuppressant which will cause gingival hyperplasia? Cyclosporine is the one which leads to hirsute appearance, and also the gingival hyperplasia is what need to be remembered.